I agree with Professor Wang regarding HR-positive breast cancer. How about precision testing? I think, we would prefer when there is relapse or metastasis, we can do more testing, especially PAM pathway. I also have a question regarding ESR1 testing. Maybe I can ask Dr. Curigliano. So maybe later. I start my statement first. In post-CDK era, how do we differentiate? Firstly, we need to think about the previous endocrine therapy, including the adjuvant setting, when there is relapse or metastasis. In the adjuvant setting, the initial therapy, based on the duration, we can see whether it is primary or secondary endocrine resistance. In the relapsing phase, we also need to look at the previous treatment, whether it is endocrine sensitive or not. So in post-CDK era, we think not only to differentiate endocrine primary versus secondary resistant, but also back to the first question regarding HR-positive precise testing. Because we see a lot of experts asked that in PAM mutated situation versus no mutation, we do see different studies showing the difference in MPFS. So if you test in this timing, the genetic testing are not only giving you the guidance on medical treatment, but also to indicate the timing for CDK, for duration of CDK, we can predict that. In our center, we actually have the PIK3CA PAM pathway testing through pathomics. We would like to do some prediction there, and we are doing part of the job and research there. And for HER2 ADC and TROP2 ADC, I think the selection of the drugs relies on the previous therapy used, from chemo, from adjuvant, after metastasis, what is the first line or second line or even later line treatment. Then we can make the decision accordingly, because both agents for HR-positive patients, HR-positive negative patients both, you can't differentiate which is better. You still need more clinical study to guide our decision making. Then a small question to Dr. Curigliano.
Professor Curigliano, are you online?
Yes, which is the question, because there was a huge background. Yes.
Okay, I have a question about the HR testing for the early stage breast cancer, because we know the leader clinical trial, some replaced the stable endocrine therapy. So I want to ask you, do you think the patient need to do the ESR1 testing during the therapy? Because the clinical trial don't do this work for the patients, but we know the ESR1 mutation is how to say is currency during the therapy. So if the patient use the SERM at first during his adjuvant therapy, do you think we need to do the ESR1 testing for the patients is better, or don't need to do this? We can, according to the literal trial, to do this therapy for the patients. Thank you.
Regarding the lidERA trial, giredestrant is still not approved, and so we don't have, of course, this problem now. The probability to get an ESR1 mutation in the adjuvant trial is very low, is less than 5%. According to some studies, less than 2%. So I don't believe we need to test for ESR1 in the adjuvant setting, because in my opinion, the benefit of giredestrant in that study is related to the fact that the oral SERD works both on ESR1 mutant and not in ESR1 mutants. So to answer to your question, no testing for ESR1 during the adjuvant therapy.